Okay, so welcome everyone to a session hosted by the Canadian Arthritis Patient Alliance, or CAPA. My name is Dawn Richards. I'm one of the volunteer vice presidents of the organization. And today we're going to be talking with our medical advisory committee on the topic of arthritis, COVID-19, and vaccines. So I'm joined today by Dr. Cheryl Barnaby, Dr. Janet Pope, and Dr. Carter Thorne, who are all part of our medical advisory committee. And they're going to have a conversation with me about some questions that we've collected that we know people are interested in on this topic. So I'm going to get rid of this slide here. And that way you can just see all of us, and we'll start a conversation here. So first of all, Dr. Pope, what does a vaccine do, and what's herd immunity to start us off?
So excellent questions, Dawn. So a vaccine is usually by injection, sometimes oral, that will try to prevent an infectious disease. So for instance, little kids are vaccinated against Haemophilus influenza and measles, mumps, and rubella, and diphtheria, polio, pertussis. And those things are all to try to prevent that that baby or child won't get the infection, the infectious disease. And that's the same with adults for influenza shots. So the flu shot every year is recommended to try to give us as Canadians immunity to not get the infection, or if you get it, to get it less serious. When you think about herd immunity, a way to try to stop this pandemic is to have enough people immune against COVID-19 infection, so that we can get back to some kind of new normal life and our economy can start up better and things. So herd immunity in a nutshell is that enough people have either the natural infection or the immunity by a vaccination, so that those who aren't immune, they didn't maintain an immune response, they didn't have the opportunity to be vaccinated, or a vaccine didn't work, or they even got the natural infection and didn't have sustained immunity, there's enough people around them that are immune so that it protects that vulnerable person. And we think of herd immunity as for instance, say if there's a little child on chemotherapy, or if there's an adult whose immune system isn't as good for various reasons, if enough people around them are immune, that person's far less apt to get the infection.
Okay, so immunization.
A more concrete example is the example of measles, which for decades has not really been a problem for the Canadian population. And now we have certain areas of the country, sometimes they're cities or towns where there's a significant predominance. And we've heard now where measles is occurring in the school age kids. And that's because a sufficient number of people in that community have stopped getting the vaccine as a majority or plurality, and now the kids are now exposed. So that herd immunity was based on the majority of people getting their measles vaccine. And when you get below that threshold, whatever it is for measles, which is quite infectious, then the kids will start getting sick. And that's a real concrete example, and everyone's heard of that example, I think, of the impact of herd immunity. Good when everyone's getting the vaccine, and not so good when groups of people, especially larger groups of people within perhaps a community within a city, stop getting their vaccines.
So immunity and getting the vaccines, not only to protect ourselves, but also to protect other people around us. Could be vulnerable individuals, could be people on different types of medications. So, you know, it's pretty exciting that just a year into a pandemic, we're actually talking about vaccines for this specific infectious disease that's nearly unheard of. So, and really exciting because as of just yesterday, Health Canada had approved the 4th vaccine now for COVID-19. So Dr. Thorne, I'm going to pass this over to you to share with us a little bit of information about the 4 currently approved COVID-19 vaccines in Canada, and how these vaccines work, because they each work a little bit differently, but the goal really is the same here. So I'll pass it over to you, Dr. Thorne.
So when Janet was speaking about some of our traditional vaccines, most of those are based on taking a virus and doing something to it so it doesn't become so infective. So it's inactivated or somehow attenuated. The 4 vaccines that have been approved now use new technologies, which are going to make a big difference for our future plans. One of the fifth vaccine that's on the line is going to be using old technology. So the new technology is not taking a virus and squashing it up and distilling it. It's actually taking a protein that's on the surface, which stimulates your system, your immune system, and my immune system to protect ourselves, and just giving you that protein, so that your body then recognizes this abnormal protein. Everyone's seen the ball with the spikes on it. Those just taking those spikes. Now they've done it 2 different ways, and you've heard about the mRNA, and that's because we have that technology back from developed in the late 90s of sequencing DNA, then going back and forth and back. And now they can look at the protein from that spike and make a DNA and then make a messenger RNA, and they stick that in you, and your body will use that messenger RNA, which is short-lived, to then make proteins, i.e. the antibodies against the virus. So you're not getting any virus active particle at all. So the 2 agents that we have currently available at this very moment that you're getting in your arm are the Moderna and the Pfizer, and these are both the RNA vectors. One of the characteristics is that they are awkward to store and to hold, so that's a bit of a problem, and they both require two injections. The other ones that have been recently approved are using a vector, a viral vector. You say, viruses, I just trying to avoid virus and you give me a virus. Well, these are viruses that originated in another fashion, and they are not at all infective for people. They don't multiply in our bodies, but they can carry another piece of DNA that we just spoke of, and that's why they're called a vector. So you take a virus that doesn't infect, that can't be reproduce in you, but can carry a DNA that then is put into your cells, just like your body now is stimulated by this DNA that will cause you to make the antibodies. So in one case, you're giving a protein to make the antibodies. In the other case, you're giving the DNA. One of the advantages of the newest guy on the block, the Johnson & Johnson or J&J, is that it is very easy to handle, and it looks more like what you see in your doctor's fridge. He just has to keep it, he or she just has to keep it well refrigerated, no extremes of temperature, and it's good to go. And in that instance, and as we roll out and have more experience, we're going to probably have our healthcare providers and pharmacies administering that, because the handling is so inconsequential compared to the ones that are currently available for our population.
So basically, these vaccines are stimulating our bodies to make antigens against the COVID-19 infection.
When Janet was speaking about getting the immunizations in the past, it was always the same piece, but our only stimulation tools before, going way back to smallpox, was to give something that looked like that virus. In that case, it was cowpox originally, and now we use other things. But we used to use the real virus, attenuated or weakened, to stimulate us to produce it.
Okay.
Remember, our body does this all the time as a natural phenomena. We cut ourselves in the garden, we get some bacteria in. We usually harness our body's immune system to shut that down, whether it's a bladder infection or a skin infection or whatever. What we're trying to do now is enhance that and prepare our body for the real assault.
Okay, the next thing I wanted to ask is, some of these vaccines require 2 separate doses. So I would like to ask you, first of all, why that's potentially the case. And second of all, if you can talk about some of the side effects. I've seen some things on social media and in the media too, about potentially the second dose causing a few different side effects, or maybe more noticeable side effects. And so can you just talk generally about that kind of approach, this 2-dose approach, as well as about some of the side effects, Dr. Thorne?
Yep. So 2 doses is not uncommon for a lot of things. And remember, Janet again mentioned that as adults, we've often received booster shots of things to re-stimulate our body's immune system against the virus immunizations we had as a kid. So by re-engaging or re-exposing ourselves to those antigens, which we haven't seen a lot because of this herd immunity that we talked of, we are really stimulating ourselves to be prepared again. We're reinforcing our body's immune system. So some of our newer vaccines are also 2 doses. And so, for instance, the shingles vaccine or the zoster vaccine, they require double dosing. And again, that's to give you the first touch of it, and then to give you a boost on it, because your body's now prepared and will have a greater stimulation the second time to enhance that immunity. Now, we have seen in the past week where Canada has suggested, the Canadian advice now is to move that 3 and 4 week stuff that was there for the Moderna and the Pfizer. And again, those were not magic numbers. They were just the ones used in the study to even further out. Again, to give the body's immune system a bit of time to develop and become mature with that first dose, and then to get reinvigorated with the second dose. Now, there aren't any studies at 4 months, to be clear, but there's a belief that may indeed be even more enhancing. So you do get response to the first dose. And remember, again, we spoke of the flu vaccine, which actually has about a response rate or a protection rate of about 50%. These ones, in their worst, are sort of 65 to 75% after the first dose. And after the second dose, they're in the 90s range, as the people are aware. And so this is really an attempt to get you the best you can be for a pretty infectious type of disorder.
Okay.
In terms of the side effect, in the past, side effects were often thought to be, oh, this is because they made it in an egg white or something like that. Or I got the flu because I had the flu virus injected into me. Some of that was a bit true, but now that technology is quite a bit different. However, you do still have the inflammatory reaction as part of your body's immune response, that is response to the local injection. So just like they remember, inflammation is a normal part of the body, and most of our audience today have an autoimmune disease, means that you have the stimulation from within. We're giving you a stimulation from without. So whether you get a bad other flu, gastroenteritis, or a bad bowel infection or bladder infection, a lot of those symptoms, for instance, in a bladder infection, it burns when you pass your water. But the unwellness is actually your inflammatory reaction occurring, not necessarily that the bacteria are all over your body, which they may be, but most of the unwellness is associated with the body's inflammatory reaction. So in this regard, because you're not constantly exposed to the antigen, in this case for the COVID vaccine, you're having an inflammatory reaction. We want that to happen. That indicates that your body's doing what it's supposed to be doing, responding to the protein. And thus, in those circumstances, because there's no ongoing stimulation, it usually goes away in a day or two.
Okay,
and
perfect.
It's usually tenderness at the site of injection, fever, sometimes headaches. Some people have complained of just general lassitude and unwellness, like they have a flu, and then that goes away.
So that's a lot like what I've experienced myself just with a flu shot, right? My arm is sore. I generally don't feel well for a day or whatever it is. So that's basically my body doing its job based on that vaccine. Okay, that's
more
great
and more that's
people.
the case. And I mean, I've been getting a flu shot for the last 30 years every year, and I always had a reaction at the beginning. And now infrequently I get it, because again, the technology has changed and how they synthesize and how they deliver it.
Okay, thank you. Over to you, Dr. Barnaby. We've got a question here about how have the COVID-19 vaccines been or are being tested in people who live with arthritis and maybe who are on immunosuppressant medications? And can you tell us why or why not this is the case?
Yeah, so with the original trials from both Pfizer and Moderna, they actually excluded patients with autoimmune diseases. There are actually also very few patients with HIV in those trials as well. And I'm not really sure why they decided to exclude, other than, I guess, worry, and also maybe just trying to keep things very clean when they come to analyze data. And so those original studies didn't include patients with autoimmune disease or on different immune modulating medications. But now in the observational studies, they're going to continue to follow and see what happens with autoimmune patients who do get vaccinated, and follow and see what their responses are, as well as side effects that are specific as well. And I think one of the main concerns that people had is whether these vaccines might trigger autoimmunity. So could they actually make your autoimmune disease worse or cause you to flare? And so far in the general population who've gotten the vaccines, we haven't seen a significant number of episodes where people get new autoimmune disease or autoimmune disease type features from them. And that makes sense because in some cases, vaccines are developed with an adjuvant, which is meant to be an irritant to your immune system to try to wake it up and get more of a response. And these vaccines don't use adjuvant at all. So we don't have to really think about that reaction either.
Okay, so basically, many of us were not included in clinical trials for a variety of hypothetical reasons, but we are starting to see, right, that in populations like Israel and the United States and the UK, they're having, significant portions of the population, including people with inflammatory arthritis, who are being vaccinated. So we'll start to see data from, I'll say, the real world coming out of those areas.
That was the same reason they excluded in the original advice pregnant women and kids under the 16 or 18, and those were arbitrary just because they were kids under 16 or 18 in the studies. And again, the concern, as Cheryl points out, about giving it to a pregnant woman. Really from the get-go, the specialty organizations said these are the people that should be involved. So for the kids, there's studies ongoing right now. Also for pregnancy, and the advice in Canada is women, pregnant women, as well as kids over the age of 2 generally, are able to get it, though the kids are going to be waiting, but the pregnancy are getting it. And the oncology was the other group that are kind of like our patients in the sense of a compromised immune system, usually by medications for their cancer rather than the underlying disease, but sometimes it is. But those, again, our colleagues in the oncology field are strongly advocating that those folks should be immunized for the same reasons that Cheryl has mentioned.
Okay, and sorry, go ahead, Dr. Burney.
I think some of the concern too was around whether the evidence of the vaccines working in the general population could be applied to people with autoimmune disease. And I think they were being very stringent and saying, no, we don't know. But we extrapolate evidence from the other vaccines all the time. So there's nothing theoretical that we're concerned about. And in fact, as Dr. Thorne has said, we're actually very invested in making sure that patients with autoimmune disease are protected because we know that the burden of isolation and not being able to participate socially is more impactful on in patients with autoimmune disease. And why are we trying to make things worse by now saying, you know what, you can't even come out and get the vaccine? So that's not the message we want. The message is that, yes, there is no reason to suspect that there's going to be a problem. We will continue to watch for it. And we're going to try to advocate every possible opportunity to say, let's get vaccine into autoimmune patient arms.
Okay, and I think that's a nice seg into, I think you've kind of already covered this a little bit, but I'm going to ask you to be a little bit more obvious. For a person like myself who's out there with inflammatory arthritis and maybe they're on a biologic, what would you say to them in terms of potential risks and benefits, Dr. Barnaby, of them getting the vaccine or not getting the vaccine? And maybe how should they consider weighing those? And are there tools out there to help them make this decision?
Sure. So in terms of benefits, we know from the studies that were done that these vaccines are very, very, very effective, like close to like 100% effective in preventing getting sick from COVID. And so that benefit is so massive that you can't refute it. There's no way that we're gonna be able to say, no, this isn't the truth. In terms of potential harms of getting vaccinated, again, we don't see significant adverse effects. Of course, we worry about people developing a severe allergic reaction or anaphylaxis to it, but that is a very rare event. And we don't worry about flares. There's no evidence to say that we should worry about flares or theories that we should be concerned about. So for most people, the benefits are going to be drastically stronger than the harms. And of course, the concern about not being vaccinated would be that you're not protected. And even if you did develop a COVID infection and are up for immunization, that's still very important to do because you'll get a better protection against all the variants and forms of COVID than the actual strain that you would have been infected with. And so until there's enough people in the population that are immunized, you would basically be still continuing to be on your own personal lockdown. So the vaccine does help to protect you. As Dr. Pope said before, if you do happen to get an infection after you're vaccinated, it should be less severe as well because your body is ready to respond and counteract that infection.
Okay, great. And I guess I'll just put a plug out there that CAPA has worked with the Canadian Rheumatology Association to help develop a decision aid. So it's got lots of questions for people to consider about weighing potential risks and benefits about being vaccinated. So hopefully people watch this video and they use all of the resources that are out there that we've worked on collaboratively for them to make the best decision for them, because we know it's a very individual decision. Dr.
Dawn, just to add to that is, in general, there's no reason not to get the first dose. So in general, there's not really any contraindication unless, right now we don't know the dose of, say, kids under 12 or things like that. So the answer of should I get my COVID shot is yes. So I think that helps when you're looking at the decision aid. We're not saying, oh, if you were allergic to this or whatever, because this is a brand new protein that you could be allergic to at your second shot or after your first shot. Highly unlikely, could happen, but for the first dose, there's no reason not to in general, which is really helpful, I think, for people.
And I think too, it's important for people to know that after we are vaccinated or whatever the vaccination site, I believe people have to remain for 15 minutes or so that they're under observation in case there's anything dramatic that happens at that point. Is that correct?
Yeah.
Yeah.
That's true.
Okay. Okay.
And people should remember that after the vaccination, they're not actually immune for a period of time. And so it's probably in general, your body starts mounting a response at 2 weeks. So some of the results at 2 weeks in the studies aren't all that exciting. But once you get out to the 3 and 4 weeks of measuring of your body's response, it starts getting really robust. One of the things that I speak to my patients about is not the risk that they have on exposure to the vaccine, but we are concerned about how good the response might be. And you mentioned that people on a biologic and some of our other medications might have a dampened response, and that's probably true. And again, that's an extrapolation, as Dr. Barnaby mentioned, from the flu vaccine. So those studies were done with methotrexate. So taking certain medications, not all of them, but certain ones, may be associated with a dampening of that effect. Now, if a vaccine only has a 50% response, a response rate as the flu vaccine does, losing some value, 10 or 15% of that response might be important to you. But as again, Dr. Barnaby points out, if you're at 95% and you lose 10%, you're still at 85%. So I think what we do is then, depending on your medications and your other medications, we might suggest you hold a medication for a dose or two, but not for a month or 2 or 3. You might hold it for a dose or 2, again, depending on the medication you're taking and the cycle that you're taking it in.
Okay, that's actually what I was going to ask you, Dr. Pope, is, if someone decides they are going to get the vaccine, would your recommendation be that they have a chat with their rheumatologist or their pharmacist or whoever that healthcare provider is about how they might hold a specific dose of a medication or not? What's your advice on that?
Right. So I think the first thing is we're not sure who should hold what, but we don't want things held for very long. The second thing is it depends on if a person, say, is on their biologic and their methotrexate or whatever advanced therapy and or other conventional synthetic disease modifying drugs, and they are flaring a little bit already. I would rather not have them hold, because if they hold their methotrexate, say 1 or 2 doses, and then 3 or 4 or 5 or 6, 8 weeks later, they get their second dose, if it's Pfizer or Moderna, depending on the schedule, then they really could flare. And if you flare, you tend to take prednisone, glucocorticoids, intramuscular injection of corticosteroids, and that might blunt your response a little bit. So in general, we have different guidelines. So in the British Rheumatology Society says, don't hold anything, just get on with it. In Canada and the US, we're a little bit more open to saying, well, for the flu vaccine, holding 2 doses of methotrexate gave a better response to a viral particle than not holding. And I think really the only things that I would actually worry about for my patients are the timing with respect to rituximab. Rituximab can blunt a response to a vaccine. It can blunt a response to certain infections. And even though the infection rate of rituximab, people taking it for vasculitis, rheumatoid arthritis, other reasons, even though the serious infection rate on that medication is not sky high compared to the other ones, you might not get as good a response. So the timing of rituximab, probably not. If you got rituximab 1 week ago and now you're getting your vaccine, maybe your response will be blunted. So closer to halfway between doses or even before the next dose, something like that. And also high dose glucocorticoids. So above the dose of about 15 milligrams of prednisone. So that might be people with vasculitis, inflammatory myositis, things like that. You might not get as good a response. Does that preclude you from getting it when your number comes, like, okay, you're in the group now that can get it? No, just get it. Because a blunted response is better than no response, in my opinion. And we still think that these are safe products, the vaccinations for our patients.
Okay. The other thing I wanted to,
I'd certainly support Janet's comment there. It's like Dr. Fauci in the US states, better to get it than not get it at all. And we saw this a lot with the flu vaccine in the fall when there was a great demand and patients were waiting for their pharmacy and whatever, and they were waiting and waiting. And, I think that was a challenge. If you have an occasion, as Dr. Pope mentions, that your name comes up or your group comes up next week and you say, well, that's out of my cycle, like I shouldn't get it. No, get it. You're better to get it now than take the chance that you might miss it, and chance to be exposed. Any response is better than no response, as she states.
okay. And what advice, I'm going to start with you, Dr. Pope, in terms of, we talked a little bit about, you get vaccinated, but it's a bit of a process to actually build immunity. So should people with inflammatory arthritis continue to social distance, wear a mask? What kind of precautions do you advise on that front?
Right, exactly. So again, until we have herd immunity, we will still have to do quite appropriately what our public health measures in our region are. So social distancing, only going out when necessary in certain gray zone or the different color zone, hand washing frequently and wearing a single mask. And there's even some discussion if you're in an area with the really contagious UK version of the strain of the COVID-19 strain, to even consider at times double masking. So look at what the website in your area recommends for the public health. In addition, when you're vaccinated, it probably takes a good 7 to 12 to 14 days to mount that response. At first, we mount the IgM against something and then IgG, which protects us for longer. And a lot of people in the know that study vaccines say, well, you're probably fairly protected by 2 to 4 weeks after the first dose. And one of the COVID vaccines now is only 1 dose. but the ones we're all used to, Moderna and Pfizer, are 2 doses, but you still wouldn't just say, oh, I think I'm going to now like travel all over the world during a travel ban, things like that. So I think really until there's herd immunity, the recommendations are still going to be put in place, number one. And number two, what we don't know, all these vaccines had as many people as any other vaccine in the trials that went to market. What we don't know is how long does the immune response last? And we're hopeful that we will know it's more than 6 months or 9 months. And we'll know that by all the randomized controlled trial participants will get looked at long term. Yep, still X% are immune at 6 months, 9 months, 12 months, etc. So that's the other unknown right now. And I think the third unknown that scares us, scares patients sometimes, is, well, what about these rogue mutations? So we're all used to the flu shot. We get the flu vaccine on what the expected mutations will be that come to North America after influenza often starts seasonally in China and then comes our way, so to speak. So far, the rogue ones of the UK and the South African one, and probably the South American or Brazil one, are still, our vaccines are still effective. I say so far, and we expect mutations. I was actually surprised at how few mutations there were in the first wave, because it takes time to mutate. But so far, our vaccines seem to be effective, we think, against the mutants, and maybe they're dampened in their effectiveness and maybe not. But over time, mutations might occur that vaccines that are not the front runners, but the other ones in process might be more effective down the road and might come out for an annual or a Q5 year or who knows what booster or new vaccination. So far so good, but some of the mutants are more contagious, not necessarily more severe if you get it, but more contagious, so higher chance of getting it.
Okay.
So remind your listeners that the flu is much less frequent this year. Now, more people got the flu vaccine, were made aware, but it's more than that. And it appears to be the social distancing, the masking, and the hand washing, which has made a difference. When people think, well, this is just crazy stuff, if we just look at the flu and the impact that this activity, which is the same kind of activity for COVID, has resulted in marked reductions. And the last week when I was listening, they couldn't even say there had been an outbreak of the flu in the Atlantic provinces. There hasn't been enough flu in the rest of the country to determine what the incident variety is this year. There just hasn't been enough flu infections. So whereas last year we were concerned about having a double hit this fall of the flu and COVID, the flu didn't come by. And that is mainly because of the public health measures that we all took.
Yep. And I can tell you, amongst the CAPA board, we've had lots of conversations about the things that for us aren't going away post-COVID. So that's really good hand hygiene. I think we all carried our hand sanitizer with us before, and maybe now we're a little bit nerdier and we wipe more things off when we're in public. And maybe for some of us, masks stay on in some of the public places that we're going to. So one more question for you, Dr. Barnaby, and that's, given everything we've discussed, does any of your advice change for people who are maybe over 65 and live with autoimmune rheumatic diseases, who might have maybe more other comorbid conditions than, I'll say, the average person who lives with an inflammatory disease?
I think we've learned so strongly from COVID how age is a significant risk factor for dying from COVID or having the more severe consequences like having to be in hospital or ICU. So I'm probably even going to be more stringent about recommendations that people over the age of 65 do get vaccinated. One of the issues, of course, is the AstraZeneca product is not tested or approved for people over the age of 65. And I hope that we get some evidence that it's also helpful there. That would be great. But I guess it is a way to make sure that there's actually vaccine supply for people under 65, which will be the majority of patients in the arthritis community. So I do hope that people over 65 recognize how critical it is for them because of their risk of an adverse consequence of getting COVID, but also that perhaps this is a way to balance out the distribution issues and have the rest of the community immunized.
Okay. And I think that that's going to wrap up this part of our conversation about arthritis and really COVID-19 vaccines. I'm just going to ask if there's any kind of take-home messages that you'd like to reinforce. So, one of the ones I heard is get the vaccine, whether it's just the first dose or whatever it is, like really, you shouldn't hesitate. Feel free to, look up whatever information you need, but this is coming from people who take care of people who live with inflammatory arthritis every day. So you see it more than everyone else. So that's one strong message I heard. Any other messages that you'd like to reinforce? And maybe I'll start with you, Dr. Pope, go to Dr. Thorne, and then ask you to wrap up, Dr. Barnaby.
So the COVID vaccines are highly effective and safe, including, I believe, in the community of inflammatory arthritis, other arthritis and related conditions.
I would reiterate that. I think we have to emphasize that everyone in our practices should be receiving or considering to receive a COVID vaccine. We do understand that there's lots of noise out there and counter or contrary opinions. And I strongly recommend to my patients, if they have a contrary opinion that they're concerned about, don't hesitate to give us a call so we can discuss it and its value or non-value. Oftentimes information is unfortunately misguided or incorrectly interpreted. And I want to make sure the people in my practice are aware that we have an open door policy. We feel so strongly about getting the vaccine that we feel that we can counter any argument that they might have.
And I guess my message would be that we're not only doing it to protect our individual selves, but also that larger community and the people around us that we care about. And that we also would, just stress the importance of continuing to protect yourself in that period immediately after your vaccine, just in case the response isn't complete and full yet, but also to continue to practice all those good behaviors that have protected you against influenza this year, other infections that may arise in the future too.
Okay, great. Thanks very much, everyone, for your time today. Hopefully that answered a lot of questions for our community about living with arthritis and the COVID-19 vaccines. And I'd also like to invite people to check out our website. We've got lots of information and up-to-date medical and scientific information about COVID-19 and the vaccines there. So thanks again to our Medical Advisory Committee for working with us on this today.